Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today, we'll be discussing telehealth. The COVID-19 pandemic has led to a dramatic increase in the use of video conferencing technology to create virtual doctor's visits. But will this boom in telehealth last? And what does it mean for rethinking healthcare delivery in the future? Well, we'll be exploring these and other questions with my guest, Dr. Marty Doerfler. Dr. Doerfler is the Senior Vice President of Clinical Strategy and Development for Northwell Health. He also serves as the Associate Chief Medical Officer for Northwell and oversees the Office of Clinical Transformation. He's also a Professor of Medicine and Science Education at the Zucker School of Medicine, and I'm delighted that he's with us here today. So, Marty, welcome to Well Said.
Great to be here, Ira. Thank you.
So I use the word telehealth in my intro, and I think it's probably a term that is familiar to a lot of our listeners. Could you define it for us? What do we really mean when we say telehealth?
There are a number of different terms out there, and they're not 100% accepted in generic. But probably the best way to differentiate, the term telemedicine was really the first term in this space, generally used to describe the interaction of a patient and often their doctor together with another physician somewhere else. And actually, the rules around the delivery of telehealth, even for up until the pandemic, have required that the patient be with a primary care provider or a provider who's responsible for them in one way, and that the telemedicine physician be distant but connected to that nexus of partnered doctor and patient, really looking at physician in New York helping with a patient in rural Montana type things. Telehealth was the broadening of that term to recognize this is not just physicians, but there are a number of providers of care, nurse practitioners being very close to physicians in most of what they can do, but nurses in general, diabetic educators, lactation consultants, a broad array of healthcare providers get involved in using the telecommunications equipment. And it also differentiates that a telehealth visit is generally one where there is an audio-visual connection as opposed to just telephone. So Bringing that down, an audio-visual connection of a provider of healthcare from a distant site to a patient in their home or office is generally the definition for telehealth now.
If we take the patient's perspective here, walk us through what a typical telehealth visit might look like.
When most patients think of a telehealth visit, they're thinking of them being at home and talking to I'm going to use the term physician here. I just gave the broader definition, but most what patients would think of there is them talking to a physician. To be clear, telehealth is used sometimes within hospitals, from one hospital to another, covering an emergency department. And so a patient might be in an emergency department seeing a stroke neurologist when they're there with difficulty moving their arm. It's not what patients generally think of. What they generally think of is I'm at home and I have a medical problem, and on my computer, more often than my phone or my tablet, all of which are capable technically, I'm having a video visit with a doctor. And that doctor might be a doctor I've never seen before. The virtual urgent care space has been built on that model. Or it might be my doctor who I saw 3 months ago for the same problem and it's getting better or worse. Or it might be 3 months ago I saw my doctor, but I have a new problem.
But how does that connection get made? These are appointments made as you would make an appointment to see your regular doctor, but then you sign onto a website or you open an app, or how does that work?
All of the above. First, given that, as I said, there are different varieties of this, the virtual urgent care space, you can go on to any of the commercial providers, or if you know of the urgent care entities in your community. Northwell has a partnership with Go Health. Go Health has virtual urgent care during normal business hours. And you go on and you register, and you have a time set, and you click on the link, and you have your visit. Similarly, within Northwell right now, you can schedule a visit with your doctor. I actually don't practice, as you know, Ira, but you do. You have office hours, and you and your colleagues could have your patients schedule a telehealth visit for tomorrow at 2:00 to talk about how my chest pain is better on the medications you started me on a few weeks ago. Mm-hmm. And in that, there are a variety of different ways that can occur, and it depends upon the tools that your health systems use. The doctor themselves can send you a link by phone, by text, or email, and you click on the link and you go right into the visit. At Northwell, again, we have the digital patient experience portal, and if you have your digital patient experience login, you can go to the website, and your appointment will be there, and you'll click on the link in the website just as you would to click on buying something at Amazon, or you have the app on your phone or iPad, and at the prescribed time, you would click on that link, and you would go into the virtual waiting room, and your doctor would either be there waiting for you, or hopefully you'd be there a few minutes before, and your doctor would then come on at the prescribed time, and you begin your visit.
Okay, so we're going to talk about the technology a little bit later, because I think what you just described works great for people who are well connected and have a tablet or have a computer or something like that. But before we get to some of those technical issues, I mean, it's obvious that the interest in telehealth and the surge in the utilization of this started in the pandemic because there was such a concern about actually being in the same room with another human being. What advantages might there be to virtual visits outside the context of concerns about actual human contact?
A couple of things. And one of the pieces that I thought was a major driver of telehealth during the spring of last year and remains now wasn't necessarily being in the same room with your doctor or the nurse or the like, but was getting there. The transportation, particularly, you mentioned that there are people who have struggled with the technology here, but many of the same communities that struggle around having the right technology also don't just go out and hop in a car and drive to their doctor's office. They have to take public transportation, which is still now riskier than driving your own car. And, one of the things I've talked about for some time is that, individuals we're here on Long Island right now. The attention to telehealth has been around distance for some time. The hypothetical I raised earlier on about a doctor in New York and a patient in rural Montana, long way away. There is no cardiologist nearby for that patient in Montana. You can talk to somebody in New York or Rochester, Minnesota, or wherever else you happen to be able to make the connection. And so there is the ability to have more services at the location of the patient than are physically there. Mm-hmm. But even if you take an area like New York and Long Island, I often use as an example, where there is no public transportation between the north and the south. Right. And so an individual who does not have their own transportation to get to a doctor that they need to see for a problem can be there and back an all-day affair, which might be a 15-minute audio-visual visit on their computer, again, assuming they have one with right connectivity, with their doctor to say, it's okay, or here's what I want you to do, and your prescription will be at the drugstore down the corner from you. So eliminating all the time involved in going back and forth between where the patient is and where their clinician is has always been a real benefit to this, and that's not changed at all.
Well, so that begs a pretty obvious question, which is, if it's that convenient, then why didn't this take off any sooner?
Finances is probably the biggest piece of it. So Medicare doesn't cover everybody, obviously. It covers people 65 and above and with special circumstances, disabilities, and the like. But private insurance often creates its policies and procedures on the basis of Medicare. So Medicare is the 800-pound gorilla in the marketplace, driving what services are offered, covered by insurance. And for a very long time, and still present now, and we're hoping that this is going to change, the Social Security Act of, sometime in the 80s actually forbid Medicare for paying for telehealth services other than in specifically designated rural underserved areas. And I mentioned this briefly as I started in, and other than the patient is physically in the office of a physician. So it was designed around the hypothetical I've given of a doctor in New York and a patient in their family medicine physician's office in Montana. And so trying to, in New York State, we have commercial coverage parity, meaning that if you have commercial insurance, they have to cover telehealth the same as an office visit, but they don't have to pay the same. In Connecticut, they have payment parity. So if a doctor gets paid $100 to see a patient with high blood pressure in their office, they get paid $100 to follow up with that patient, whether they're getting better on their medications by telehealth. But in New York, you got paid $100, the insurer might pay you $10. And it's not so much about the money as it is about the uncertainty. Any business that is going to be successful needs to know, and healthcare is at one level of business, unfortunate as it is, any business needs to at least know what its costs and its revenue are going to be. And so that uncertainty has led people to not try this. And particularly given the fact that you and I, we're of similar age. We've trained, more than a decade ago.
More than several decades ago, yes.
Yeah, okay, more than several decades ago. And this was not what we were trained to do. And so, doctors and nurses and physical therapists and everybody else are comfortable doing what they've always done. So you take economic uncertainty with, I know what I'm going to do if you come into my office, and I have an office staff that can help with all sorts of things, and now I'm going to be trying to do this in an audio-visual visit, and some of the things that I get, like listening to your lungs, I'm not going to get. So that combination has led to real hesitancy prior to the pandemic to put these forward as real opportunities.
So let me just try to summarize what you just said. So it's financial concerns, if not barriers, concern about teaching us old dogs new tricks. I would characterize them as kind of old-fashioned regulatory barriers to making this more widely available. Does that sort of sum up the landscape?
Yeah, and I want to add one thing to the old dog's new tricks, which is it's not just the physician or other clinician doing this. One of the things that is missing from the routine telehealth visit I described earlier on is all of the other things that occur in an office. The patient who has a relationship with the doctor often has a relationship with their office staff too. They go in, they're met by somebody, they can check and see whether or not they have a copay. They have somebody take them and put them into a room and instruct them on what to expect and whether to be undressed or partially undressed or whatever. A nurse or a nutritionist or, with your child, the educator, any variety of other folks come in and interact with you. Then the doctor comes in, you have that interaction, and you leave and you check out at the desk and you get your next appointment and your prescription and all sorts of other things where you need x-rays, all that stuff set up. All of that wraparound that exists in the modern office does not currently exist in most circumstances in this virtual space. And that's the next hurdle that you and I and our colleagues are going to have to do to really make this an experience that provides the right health care to our patients, is to create in the virtual space all of those things that are really a fundamental component of the healthcare delivery apparatus and experience for patients in the physical space.
Right. No, I think that's a really good point. We tend to reduce the office encounter to just what happens in that exam room between the clinician and the patient. But you're absolutely right. There's a lot of other stuff before and after that's very valuable to the patient. And I think that's a point well taken about trying to recreate that in this virtual world. I want to pick up on something else you mentioned, which was the fact that you mentioned something about listening to somebody's lungs. So obviously, it's pretty tough to do a physical examination through a telehealth connection. Talk to me about what's being done to address that, and how does that limit the current utility of telehealth?
Let me start by modifying your statement. It's pretty difficult to do certain elements of a physical examination through telehealth.
Okay, fair enough.
Behavioral health as one of the booms here over this whole piece, and behavioral health doesn't have any real physical exam, but you do have visual cues that are maintained, and you have inflection, and there you may actually have some things about the patient's living environment that are an enhancement of having them come to your office. A neurologist who specializes in movement disorders, particularly for a patient that they know, I started an individual on medication 6 weeks ago. I'm expecting their twitching or whatever other problems they have to get better or not. That type of an assessment is often quite visual and is going to be reproduced fairly well without having a stethoscope or other tools. We do tend to focus on things like the stethoscope, and you're a cardiologist and I'm actually a pulmonologist, so I've not practiced that in a very long time. I've been mostly an ICU physician, as you know. And you cannot listen to the lungs. However, there are a couple of pieces here. One, in certain circumstances where the patient might actually be in a skilled nursing facility or the like, as telehealth can occur to those places, a nurse or physician assistant or others might listen for us and tell us what they hear, not the same as us hearing it ourselves. Second, there are devices out there. There are Bluetooth stethoscopes. They need to be perfected. They don't give you the fidelity of the device in your hands, placing it on the patient's chest and hearing that, but that technology is moving in the right direction. Mm-hmm. But I will add that as a pulmonologist and as yourself as a cardiologist, there are some things that you can see. For instance, I can see if the neck muscles are being used by somebody who has chronic obstructive pulmonary disease. I can see if their nares are flaring. I can see some elements of how hard it is for them to breathe, even if I can't put a stethoscope on their chest. And so I lose some of the information that I have by them being in the office, but I don't necessarily lose it all. And that's where it comes down to, did I get enough information to be able to make a decision and guide this patient on their care? Or do I need them to be in the office because I need that additional information that I can only get being physically present and being able to touch them?
Well, I think there's a related issue here, too, which is that I think doctors rely less and less on the physical examination than they used to.
Oh, certainly true. When I was working in the intensive care unit, I rarely used my stethoscope because there I had ventilator settings and x-rays and everything else, and the physical exam was far less relevant other than when the patient initially came in. In your field of cardiology, if you got an echo on a patient within X period of time, or now we're moving, this is not part of the telehealth, into remote patient monitoring, and there are devices that may actually be telling us what their breathing pattern is, what their heart rate is, blood pressure, and other things that might actually be good surrogates to tell you the patient is better or not better or worse without you listening to their lungs. And I think part of the evolution of this is going to be, what additional digital tools can we bring in, and can we all learn how to put a constellation of information together of some of the things that we get with our eyes and our ears and talking to the patient, and some of the things that we get from other sensors that make up for and may even be better than what we've classically gotten by putting a stethoscope on a patient's chest and being able to listen for crackles if they are eating a little too much salty soup.
I'm glad you brought up the technology again, because it brings us back to what somebody needs to have in their home in the way of technology, even for the basic kind of telehealth visit, leaving aside whether they have some new fancy electronic sensor that can help substitute for the physical exam. So what do we do for or with folks who don't have broadband internet access or don't have a tablet or a laptop computer at home?
The big issue here is the broadband. I mean, there are inexpensive Chromebooks these days, and there's some money to subsidize and the like out there. The hardware in the home can often be dealt with a relatively modest expense, and there are some funds coming out. The New York State has recently put some money into this. The infrastructure bill actually is going to hopefully address some of the internet issues. The big issue is bandwidth. But one of the surprises to me during the spring of 2020 with the initial COVID crisis, I'm talking to you on a cell phone right now, and I have unlimited minutes on this phone.
Right.
Is that many people with economic stress in their lives, which is a significant fraction of our community, unfortunately, may even have a smartphone that can handle televisit or a tablet, but their plans have so limited minutes that they run out of them by their kids are home for school or other sort of things, or somebody watched the baseball game last night, my minutes are up. And so that becomes a real issue there. But in general, having any modern computer and or smartphone or tablet, and again, just a basic, a dumb internet book, like the Chromebooks and things like that, which again can be relatively inexpensive. So I hate to say anything's truly inexpensive. The big issue is bandwidth and the ongoing plans. I mean, an internet plan can cost quite a bit, and underserved communities, both rural and urban, often don't even have internet connections to make. A lot of people have thought that the 5G revolution might solve this, but I've been told by the real techies that I know in this space it's going to be a long time before that solves it. And one of the issues there is that everyone's focusing on putting 5Gs into the same communities that the money lives in already, right, because that's right, where their business is. So this is a real issue, and it's one that, to some degree, the private companies in this space are beginning to address on a small level, but both New York State and the federal government are putting significant funds. New York State trying to do through community groups, and you probably know here the work that Deb Salas-Lopez and her team have been working on, trying to connect some of those dollars to some of those groups in the communities that are at risk. And then the infrastructure bill has a significant amount of money to increase broadband in the country. And the real thing there is to make sure that it gets into urban communities, not just into rural communities, because everybody thinks that the lack of services is a rural problem, and it's really an underserved neighborhood problem.
So that's really interesting. So it's not so much a hardware problem as it is as you said, internet access and availability of connectivity.
The equivalent of the Rural Electrification Act of the 1930s. I mean, once you had electric everywhere, people went out and bought light bulbs because they had a reason to have them. And again, if you had good internet connection in your neighborhood, getting a device to connect to that is nowhere near the hurdle of having the connection and the ability to afford the monthly payments.
So let me ask you another kind of economic related question, which is, I've read that some of the reluctance of insurance companies and other people who kind of pay the bills for healthcare, some of the reluctance on their part expanding telehealth is that they think that it's going to not so much substitute for other care, but just augment other care and therefore drive up overall expenses. What's your response to that?
Well, there's a chicken and the egg here as to, what you start with. And so we talked about the virtual urgent care piece, which is what many people have been familiar with for some time. There was a business there, and the cash basis of that was modest. I mean, you could have a virtual urgent visit for $50, maybe $100 under some circumstances. And a lot of those visits were things that people did not go to their doctor for. And so it looked like that care was just an additional expense that wasn't necessarily going to produce the value. They were still going to go see their doctor for their high blood pressure and their cholesterol and all those other sort of things. But that's not likely the true story, because people weren't going to see their doctor for their heart failure or other things because their doctor wasn't offering that visit, because their doctor wasn't going to get paid for it because the insurance company wasn't including it as a covered service. So it becomes a real circular argument here. One of the benefits to come out of the crisis of the last year and a half plus is that telehealth has been allowed to be used for truly anything. And we actually participated, Northwell, in a project with an entity called CTEL, Center for Telehealth and eHealth Law. Very long piece or whatever, but a not-for-profit, nonpartisan group that collected data from a number of health systems around the country. It actually shared it with folks from the Office of Management and Budget in the federal government, that basically is showing that it is not an additive, but it is replacing. Instead of you seeing me 6 weeks from now as follow-up in your office, you see me 6 weeks from now as a follow-up on my iPhone or iPad. And so it is not more care. It is another way of getting care.
Okay.
And so that's really beginning to shake out now. We're hoping that the data is solid enough. There is a lot of momentum in the federal government at this point on both sides of the legislative branch and on both parties, excitedly, and a lot of support in the executive branch to change some of these things to allow this to be routine and to get even better data and find out. But there has been a fear of two things on the finance side. One, it would be care that otherwise wouldn't be necessary and wouldn't achieve value and therefore is just wasted money. And the other is fraud and abuse. And the other thing that came out of the last year and a half is that the incidence of fraud in the telehealth space has been no greater, if anything, potentially less than the incidence of fraud in the bricks and mortar healthcare space, which is its own problem. But it was felt that this would be easier to be fraudulently billing for televisits than it was for regular visits, but it's just not showing as anything that is a real problem.
So that's some reassuring preliminary data around the economic impact of this. Do we know anything about the health impact of this? Are people being cared for better? Are clinical outcomes better because of the adoption of telehealth?
We really, at this point, don't have good data. And part of it is to differentiate what is telehealth and what is non-telehealth. But one of the things that I've been saying for a while now is that in 5 years, I expect we'll stop talking about telehealth because it'll all be health. And, the example I've used where I see you in your office and then I see you in follow-up and then maybe I see you in follow-up and then I see you in your office. How do I track which part is telehealth and which part is bricks and mortar health? I think what we're going to have to see is that telehealth becomes a routine offering and that patients do as well or better or not in whatever circumstances. There may be, and really be able to dig deep into this. There may be circumstances where telehealth is not the ideal way to care for patients and they don't do as well, and we need to push them to be in the office for those things. And there may be other things where patients, because a child with asthma, as a good example, who they can see their pediatrician by a televisit and correct their medications more quickly without them losing school, might actually provide better care. But it's not going to be all-encompassing. There are going to be things that are better. There are going to be things that are the same, and there are going to be things that we probably shouldn't be doing telehealth as the routine unless it's the only option we've got.
Well, that's an interesting vision for the future. Any final thoughts about where you think this field is going?
I think it's going to go forward. The genie's out of the bag. It's been said in a number of circumstances. Patients who are receiving telehealth in many circumstances are finding it valuable to them. The burden on patients of having to drive or get transportation to a physician or other healthcare provider visit it back again, particularly for some routine things. You may remember this before the pandemic. We were going to start with our telehealth around known patient, known problem, follow-up visit, so that it was not something new. You already had a relationship with the patient. You already knew what their problem was, and you were following it up so that we can minimize the chances we were going to make a mistake. Take that bucket right there. Patients' convenience is going to be far greater. So why would they willingly go back to the alternative? So I think that this is going to become routine. I think we're going to together find that some patients don't want it for anything. Some providers are uncomfortable doing it for anything. But in the middle of that, we're going to find that any patient who wants to have a televisit for a condition that they can be realistically treated by a televisit will find an appropriately trained and credentialed and skilled individual to care for them for their problems. So I think this is going to become how we do medicine for the future, and those people training now are going to wonder how it was ever different.
All right, well, we'll have to bring you back in a couple of years to see if you're right. Thank you very much for that really outstanding explanation and conversation about telehealth.
Ira, it's a pleasure to talk with you, and I'm happy to come back at any point that you want to have me back.
My guest today has been Dr. Marty Doerfler. He's the Senior Vice President of Clinical Strategy and Development for Northwell Health and a Professor of Medicine and Science Education at the Zucker School of Medicine. For more information about this program and to find past episodes, please visit our website, which is sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast, available wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.